Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to What I Tell My Patients. This afternoon, we talk about the management of ovarian cancer. We have a great faculty today, and we're really looking forward to making rounds with them, talking about patients in their practices and new clinical research. Another theme here is, why was it different to take care of this patient than another patient in the same oncology situation, but a different person? How do you individualize, particularly patient education, to the patient's own belief system, socioeconomic status, age, comorbidities, et cetera, et cetera. And we talk also a lot about the bond that happens between oncology professionals and patients and families, and how much patients value what you do. And we always like to take a moment to just take a breath and say, good job, good work. What you do is highly, highly valued by patients and their families. So, and as we get into individual cases, I think you'll see that coming out. So we have a tradition also. I forgot to tell the faculty about this, but guys, I think you've been here before. You know how we do this. So as I introduce the faculty, we're going to give them a chance to talk, maybe just for a few seconds, about what they do to get away from the job and the stresses of the job. So Dave, how about you?
Well, I have 5 kids between the age of 10 and 18.
That'll do it.
So a lot of club volleyball, and that's how I spend my time away from work.
Hear a lot about kids and pets here. Richard?
So I have grandchildren. But I think actually what so you asked us beforehand, I thought it's a great question, and I do for myself what I tell my patients to do, heart and mind, soul and body, a heart-healthy diet, be active and exercise, positive mental attitude and attend to your soul. And I think loving what you do in the moment just, makes vacation then something where you can recover.
Yeah, grandkids are pretty cool. I got a little 3-year-old myself who lives about a mile from me, and she's over at my house all the time. It's really a source of energy. So, Jaclyn?
Well, I have a 5-year-old little girl named Naomi, and so we spend a lot of time doing 5-year-old things. And so she's recently into cheerleading and pom, and so we just recently got done doing a pom clinic, and so just watching her enjoying growing up, learning new things, and like he said, just faith and family is really important to me, so just taking that time away from what you do on a daily basis and be able to rejuvenate yourself. So,
Courtney?
I also have a 4-year-old daughter who I enjoy spending time with when I'm not at work, and just doing things outside or having fun and just making the most of it.
So yeah, we don't talk a whole lot about burnout, but one of our messages, and we know a lot of you are new to oncology, is, get a life outside of work is really critical in getting through tough times. Here's where we're heading today. We're going to start out kind of providing a little bit of an overview of ovarian cancer, and then we're going to dive into the issue, particularly the issue of PARP inhibitors. It's been so revolutionary over the last few years. It really started with ovarian cancer. Now we talk about it all the time in breast cancer, prostate cancer, even pancreatic cancer, but it really started here. And you all have the most experience with these agents, and so we're going to spend quite a bit of time talking about that. But in addition, we're also going to talk about another theme that we've already talked about a number of times, which is antibody-drug conjugates. So targeted delivery of chemotherapy. There now is one ADC approved in ovarian cancer, mirvetuximab, and another, a very exciting one we're going to talk about today, UpRi, as well. And then we'll finish out talking about one of the most interesting things I think going on in oncology, so-called tumor treating fields, use of electromagnetic treatment of cancer, and it's being looked at, already approved in the use of glioblastoma, primary brain tumors, but some exciting data coming out in not only ovarian cancer, but in a couple weeks in the in the ASCO meeting. There's a big study in non-small cell lung cancer that's, quote, positive of tumor treating fields. So you may be seeing a lot of this. So up to now, it's just been GBM, but who knows? Maybe it's going to change fairly quickly. Anyhow, that's where we're heading. I want to just start out, and we're going to get to a case of a patient of Jaclyn, a 46-year-old woman with germline BRCA1 mutant ovarian cancer. Before we do, I just want to kind of set the stage a little bit. Dave, you're a gynecologic oncologist. Can you talk a little bit about how women with ovarian cancer usually present and how they're worked up and how you start thinking about an initial treatment plan for them?
Well, I think they come from all different fields. I just was reviewing a chart this morning from a primary care practitioner, OBGYNs. They usually, not that long ago, the average number of practitioners that a patient with ovarian cancer saw was 7 before they were diagnosed. But I think we've done such a better job of educating the community, our primary care physicians. Abdominal bloating, distension, pelvic pressure, symptoms which persist and worsen with time. When I talk to my primary care colleagues, they say every single one of my patients I see have those symptoms. How do I differentiate? Persisting and worsening with time should be something when we start thinking about primary peritoneal ovarian cancer.
So, Richard, can you talk a little bit about how you initially stage a patient and how you start thinking about what type of treatment you're going to start out in a patient with ovarian cancer?
So this can be a disease where you make a diagnosis, a histologic diagnosis at the surgery. You know, they present with ascites, they have an elevated marker, the CA125, 125th attempt to find a good, and it's a great marker. So they might go straight to the operating room. Now, we much more want to do a laparoscopy, evaluate operability, or start with chemotherapy. Half our patients start with chemotherapy. And so CAT scan, a core or laparoscopic, not just a cytologic diagnosis, and then a team decision about, okay, how do you make progress from here? We heard at SGO about patients with BRCA mutation, a rapid turnaround BRCA test, who the first 15 patients on olaparib as their first treatment. Fabulous, like 84% of the patients didn't need chemotherapy during first-line therapy. And just told you how far the field has moved in terms of therapeutic strategies.
Dave, you talked about the idea of using chemotherapy before surgery, so neoadjuvant treatment. Wednesday night here with breast cancer, we were talking about that, very commonly utilized in HER2 positive and triple negative breast cancer. How do you decide whether to give chemo first or send the patient to surgery? And what about the use of bevacizumab, even in neoadjuvant setting? We know we see a lot of effusions, ascites particularly in patients, and we know Bev's very good with ascites. How do you decide when you're going to give the chemo before or after surgery, Dave? And what about Bev?
You know, neoadjuvant, to Richard's point, is being more widely utilized. And why is that? Because we found that the surgeries sometimes were so big and with a high-risk complication, some patients wouldn't even get a chance to get to chemotherapy, the most important aspect of their care. And so identifying patients that are going to need to have such big surgeries or we are unable to get out all the disease at the primary surgery, or they have morbidities, which we worry about recovering, again, from surgery, we'll give chemotherapy first. Now, I think we may have gone a little too much in some ways into the neoadjuvant. I think we have some patients who may benefit from a complete surgical reduction. We could debate that another time. The utilization of Bev is if a patient, it's really indicated after surgery. But if I have a patient who comes in like I did this week, bilateral pleural effusion, she's already required bilateral thoracentesis, as well as a paracentesis with effusion, we need to win on her. She's already having trouble eating, she's malnourished. I added Bev right away in that first cycle. I tend to give 3 to 4 cycles before surgery. Most of the data is 3, there is some on 4. And if I'm utilizing Bev, you don't want to give it too close to surgery, so we hold it then in our practice on that 4 cycles. So 3 cycles with Bev, hold for the 4th, usually is my usual practice.
So, Richard, one other issue that really is very important and really more and more important in almost every part of oncology is really to look for tissue biomarkers and also germline abnormalities and mutations. And here we're thinking about germline, for example, BRCA1, BRCA2, other germline mutations, but also somatic mutations where you only see the mutation in the tumor itself. What are you looking for there? What are some of the things that you see, and how does that affect the way you approach a case?
Yeah, so there's, you ask a lot of questions.
The idea.
But they are great questions. So the simple answer is everybody with ovarian cancer should get germline BRCA tested. But many people want to know the biggest panel of genes. We actually have a clinical trial going on at the moment comparing large panels with succinct little panels of relevant biomarkers, predisposition mutations. And so patients really want to, like, as many genes as possible generally. So if you start with tissue, you must remember not to forget to go back and test the germline. 2/3 of the BRCA mutations are germline inherited, 1/3 are in the tumor acquired. And so you really need to check the family. The Australians are checking grandma's family from archival tissue, which is to try and find these families. And the sad indictment, a paper like 2 years ago from California and Atlanta, only 1/3 of ovarian cancer patients were getting the BRCA mutation, which is like absolutely shocking in the community. And so things have absolutely changed, but test everybody.
So yeah, if you see a patient with ovarian cancer, they should have had, at a minimum, a look at their tissue. If you have a germline mutation, you will see it in the tissue as well. Of course, you're going to see it in all the tissues of the body. But if you see it in the tissue, then you need to go and look and see if it is germline, because then you have implications for the family. And that kind of leads into your case, Jaclyn, because this woman had a germline mutation when she was initially worked up. First of all, what was her kind of state of mind when she first was diagnosed and she had surgery, chemotherapy? What was her state of mind at that point?
Well, if you can imagine, she's a young 46-year-old woman. At the time, she had a 17-year-old son. And so as many of you may be in the same age group, think about how would you feel when you have this terminal diagnosis that you have recently received. So of course there's a lot of emotions that goes on with that first initial diagnosis. You're coming to a cancer facility, likely you've never been there before. And so you have a lot of emotions wondering about, am I going to survive this cancer? What happens to my son? What happens to my husband if I don't survive this? And so in the initial assessment and the initial visit, it's a highly anxiety-provoking visit, and it's our job as providers, nurses, physicians to kind of help them understand and help them through the process about how this is going to happen, reassure them that we are here to help guide them through this new experience. And so, it's providing that support to them to help them get through that day and day by day.
So, of course, and I guess, Courtney, I'm curious, we don't want to falsely, reassure patients, but the truth of the matter is the outcomes for a patient like this woman with a germline mutation, with a BRCA mutation, has changed dramatically in the last 5 years. And, maybe not what most patients are expecting. How do you talk to patients, particularly those who have these kind of mutations that we know are so sensitive to PARP inhibitors, and how do you try to reassure patients?
We include that in our counseling. We say, 10 years ago, if you would have came in with this diagnosis, our conversation today would have been much different. And so we make sure that we reassure them with all the data that we found and the results that we've been seeing with patients who specifically have these mutations and responding to these PARP inhibitors. And we talk to them about, the severity of their diagnosis, but we also talk to them about these treatment options, not only up front, but if their cancer were to come back, we now have much more treatment options to offer them than we've had in the past.
So one of the issues that comes up when you do find a germline mutation is the family. It's important to offer family members the possibility of being tested. They don't always want to do that. What happened in her situation? You mentioned she had a son. Men are also susceptible to new cancers, particularly prostate cancer. On Saturday, we'll talk about this. Quite a number of men have BRCA mutations. They're getting PARP inhibitors as well. what happened in terms of the idea of testing? Did she have he had her son, brothers and sisters?
She just had one son. He was 17 at the time. He's currently 19 years old. They have yet to disclose the BRCA1 mutation, and so they just felt at the time it wasn't ready for them to disclose that BRCA mutation to him. So eventually that will have to be a conversation that they will choose to do. Her mother and father had no cancer history, but they also died prematurely in a car accident and due some other health issues. So we don't know, which one that her BRCA mutation came from. And there really isn't any other cancer history in the family except a maternal and paternal aunt who had breast cancer. So again, we don't know if it was the maternal or paternal side, but there is that concern, about her son in the future in regards to the BRCA1 mutation, risk for breast cancer in men. And so just because he is a woman does not mean he's not at risk for different cancers, such as breast cancer or potentially a pancreatic cancer, but there wasn't any of that history in the family.
So, Dave, when you have a patient who has, for example, a BRCA germline mutation who doesn't have ovarian cancer, then you start thinking about how can you prevent it. For breast cancer, you could theoretically take tamoxifen, and most people think more about bilateral mastectomy. Incidentally, did this woman have her breasts operated on?
Yeah, she's had both of her bilateral mastectomy with reconstruction.
So, Dave, how do you usually approach not only screening or prevention of breast cancer in BRCA relatives, for example, but also in this situation, would you use the same measures in someone who has a serious ovarian cancer? It may very well take her life. You're going to get chemotherapy. Are you still concerned and offer the possibility of dealing with the breasts?
Yeah, we really had to educate our surgical oncologist about this because once they see the diagnosis of ovarian cancer, many of them were trained in the area where the median survivals were 2 or 3 years. So like, oh, you have ovarian cancer, nothing more to do. Well, when we talked to an earlier question, I don't use the word cure. I don't say forever. I try to say long-term remission to my patients. But we're talking about a 50% in advanced stage ovarian cancer patients with BRCA. If they receive a PARP, 50%, about 47, haven't recurred at 7 years. Thus, they're probably cured. Versus traditionally about 15%. So we've had to educate our surgical oncologists once they're beyond that 3 to 4 years. And if you look at the curve, Solo 1, Katie Moore's paper, beyond about 3 years, not very many people are recurring. So we've had to educate them that they need close follow-up and discussions at a point. Is that 5 years or 7 years? I don't know. But with regards to prophylactic surgery, with regards to more aggressive potentially interventions.
We actually had Katie Moore, the principal investigator. This is the first of a number of studies in PARP, but that was the first one to report. She was a faculty member here last year, and she was talking about the moment that they unblinded the study, and they saw that curve, and they just were shocked, about how positive it was. So, Richard, in a situation like this, you have a BRCA patient. In the past, they would get surgery and then post-op chemotherapy. The most common regimen for a long time has been carbopaclitaxel. But now we're talking about therapy beyond that, primary maintenance therapy. Can you talk about how you think through right now how you're going to approach this in terms of maintenance treatment, and how does the genomic profile of the tumor affect what you're going to do? Do you approach a patient who's germline BRCA the same as somebody who just is somatic BRCA? What about the many patients who have nothing? There's no evidence at all of any of these types of mutations. How do you think it through, Richard? And what are the trials that sort of led you into this path?
So there are sort of 3 groups of patients. You've got the patients who have an inherited or acquired BRCA mutation. That is a perfect biomarker, it might be that you can avoid chemotherapy, even that good. Those patients get 2 years of olaparib or 3 years of niraparib, either. They're probably equivalent, and it's an easy decision. Half of the high-grade serous ovarian cancers have what we call homologous recombination deficient disease. They either have a cluster of genes that make them sensitive to PARP inhibition, or they carry a very similar gene like RAD51C or PALB2 that essentially is doing exactly the same thing in a different bit of that DNA repair pathway. And then half of the patients with high-grade serous tumors have an HRD negative tumor, a much poorer prognosis, and the margin of benefit not as good, and maybe even detrimental effects more in that group if you overtreat them with PARP inhibitors, especially at later line therapy. I think we just don't know about that for frontline therapy yet. But 2 years of olaparib for this lady transforms, more than 40% better chance of being in remission at 7 years, as Dave said. And we don't know whether they're cured till 15 to 17 years later is the best guess, but the goal is cure. So it's funny, a medical oncologist saying the word cure, but the goal is to get more of these patients cured, and olaparib does that, though we haven't been able to prove it.
So we should point out Richard is a medical oncologist and Dave is a gynecologic oncologist. Of course, gynecologic oncologists get very involved in systemic therapy to the almost usually the same extent as medical oncologists. You know, well, the theme here is what I tell my patients, and we deliberately don't want to use a lot of slides. I'm going to flip through some slides while people are talking. You may want to check it out later or check out the papers from that. But I'm always curious how people kind of explain things to patients. And I'm curious, when you saw this lady, how did you assess her as a learner, so to speak? And how did you explain to her, did you talk to her about how PARP inhibitors actually work, Jaclyn?
So after her initial treatment of Taxol, Carbo, we had the conversation about the olaparib. And of course, the physicians go in and give them all the big study details about how it's going to be important to them. Then we come in and say, okay, what questions did they have? And they have a blank stare. And so I know as you as well go into your patient's room and the same thing. So it's important as nurses and nurse practitioners, advanced practice providers, to really bridge that gap from the physician to the patient, and what does that mean? And so essentially, you know, you say that if your patient was BRCA positive or HRD positive, your tumors are susceptible to these new drugs. These tumors are susceptible that if we give you these, then hopefully they'll start dying off and killing the cancer, and hopefully maybe your cancer will never return. And so that's the goal. That's the goal of the cure. And so it's important to tell them, even though you're not receiving IV chemotherapy, this is a pill that you will take that can have almost the same side effect profile as the chemotherapy drugs. And so know that you're susceptible to infections, anemia, and the most common side effects like nausea, anemia as well. And so kind of going over that profile with the patient up front, kind of expectations up front, and to be able to prepare them for the next several months or 2 years of their life.
We're going to dig more into some of the problems that occur with patients on PARP inhibitors. But Dave, as is always the case, it seems like everything we've talked about this week, there are multiple agents that are being studied, multiple trials to look at. We talked about the challenge when you have different trials, you know, looking at the same thing and seemingly do look similar, but you don't have a comparison between the two. How do you decide what to do? So we've got a bunch of PARP inhibitors that have been reported. There was a number of options, and you also have the possibility of not only giving a PARP inhibitor, but adding bevacizumab on top of that. So can you kind of put in perspective what we know about the various options, and how do you decide what you're going to do?
So the options really have come down to two. There's actually 4 positive phase 1 trials, but really 2 active, niraparib and olaparib right now. And when we look at the trials, cross-trial comparison, we shouldn't do it, but we all do, right? And the outcomes in germline BRCA across these populations are unbelievably consistent, about a 70% improvement. And so when I talk about a patient who's going to have olaparib versus niraparib, I talk about the benefits. I look at some of the patients sitting in front of me. Niraparib has higher hematologic toxicity. Little bit of hypertension increase, especially compared to olaparib. So if I have a patient who's had a really difficult time tolerating carboplatin paclitaxel because of thrombocytopenia, I'm probably not going to use niraparib. But if I have a patient who says to me, I hate pills, I don't want to take this pill, niraparib is once a day. Really nice for patients. So I think as I look at those outcomes, the other thing which is very important, the first decision we have to make in the first line setting is, are we going to add Bev to the treatment? If we add Bev to the treatment, then our options somewhat are made for us. And the fact that it's HRD positive, I'm going to add olaparib, because that's really the phase 3 trial, though there is some data with niraparib. And then if they're HRD test negative, I'm going to continue the Bev, to Richard's point earlier, where the data on these HRD test negative, sometimes called HRP patients, is not as overwhelming, nowhere close to as overwhelming. But the Bev data is very consistent. So in those patient populations, I'm going to continue the Bev. So we really take the patient individually. If we haven't given Bev, then I tend to favor more niraparib in those patients, but it's variable for those factors.
So, Richard, another kind of interesting thing that sort of evolved over time was dosing of niraparib and the so-called weights and plates approach that came in. Initially, when the studies were done, they saw a lot of thrombocytopenia. And as a class effect, these drugs can cause cytopenias. Jaclyn was talking about anemia, thrombocytopenia, but particularly niraparib initially was seen to have a lot of thrombocytopenia, so there was a dose adjustment. Can you talk about weights and plates?
Yeah, so essentially exactly as Dave just said, if you are a small person and your platelets really tank during first-line therapy, the 300 milligram dose of niraparib is not going to be tolerated. And when they originally presented this data, it was an analysis of a trial for recurrent disease called NOVA in Mississippi and New Orleans, and they put the slide up, and it was like 100 milligrams looked good, 300 milligrams looked good, but the 200 milligram dose looked best. And so some patients are going to need a dose reduction to the 200, but almost always we start at 200 milligrams, we never escalate, and a minority of patients are going to need a dose reduction.
All right, well, let's bring in another patient. Courtney, this is a 50-year-old woman. Another patient with a germline BRCA1 mutation. What happened with her?
Yeah, she presented to her gynecologist with the BRCA1 mutation and underwent a prophylactic risk-reducing BSO, and she was found to have advanced ovarian cancer at that time. Looking back, she probably was having symptoms that were missed. She had a history of Crohn's and colitis, and so she may have been more symptomatic, and they were attributing it to some of her GI disorders.
Before you continue, let's just clarify what you just said, because it's very important and is not rare. So we talked about, Dave was talking about the idea of doing prophylactic surgery. So she knew she was BRCA1, they knew she was BRCA1 earlier.
Yes.
But Dave, in general, if you know a patient has a BRCA germline mutation, when do you want to remove their ovaries? When do you start seeing ovarian cancer?
Well, we have that conversation as early in their life as their maturation will allow. So we talk about birth control pills, limiting. Once they've completed childbearing, even at younger ages, we'll talk about removing their tubes. And then once they're at 35 to 40, depending on family history, I have patients that their mother was diagnosed at 41. We start having the conversation at least 5 years, but up to 10 years before. But that conversation should occur at 35. And depending on the penetrance and the family and the ages and all these different factors, we really don't go beyond 40. Unfortunately, this patient, I think she was 47, right, Court? By the time she made it for a planned prophylactic surgery when she was diagnosed with advanced ovarian cancer.
So a really tragic situation where this whole thing could have theoretically been prevented.
Yes.
I should mention, too, that Dave and Courtney work together. So this is Dave's patient as well. So unfortunately, again, they went in hoping they were going to cure her, take out normal ovaries, and found ovarian cancer. And then what happened?
And then she came to see us, and we talked to her about treatment options. She ultimately received 6 cycles of paclitaxel and carboplatin. And then we started her on maintenance olaparib, and she developed pretty significant dizziness. We ruled out all other causes and did an extensive workup. And anytime we'd hold the olaparib, her dizziness would improve, and if we'd restart it, even at the lowest dose level, it would return, and it was very bothersome to the patient. So we switched her to maintenance niraparib, and she's currently on maintenance niraparib now, and she's doing really well. We started her at 200 milligrams daily, but due to thrombocytopenia within the first 2 weeks of starting treatment, we had to dose reduce her, so she's currently on niraparib 100 milligrams daily.
Is dizziness something that is known to occur with PARP inhibitors? I haven't heard that.
There's a low risk reported. It's not something clinically that we see very often, but there is a low chance of having dizziness with all of the PARP inhibitors.
Is this like vertigo? Mm-hmm. Interesting. So Dave, can you talk a little bit more about the spectrum of tolerability issues this lady had? Fortunately, we have several PARP inhibitors available. You didn't even mention rucaparib, where we saw positive data. That's a whole other story we'll get into later, but mainly people are focused on these two. But what are some of the things you're thinking about, Dave? One thing that was mentioned was GI issues. What do you see? Do you use preemptive therapy as like we do with chemotherapy?
Well, we've learned some important lessons in the tolerance of PARP inhibitors. We used to say don't take them with food. That was completely wrong. Take them with food. If somebody's having GI toxicities, something simple, take it at night before they go to bed with a light snack, and they often will sleep through their symptoms. So I think as we see these different symptoms, there are simple things we can do with each one of the agents. Now, we also see some weird stuff with an agent like dizziness. We recently had a patient with itchiness. We actually switched the drug, and the symptoms did not recur. So if you have a symptom, I will sometimes switch from olaparib to niraparib with fatigue because, again, they're able to take niraparib once a day, they take it at night, and their fatigue may seem to be better. This is where the individualization and having 2 or 3 agents at our disposal can be very happy. If you have a patient who's BRCA, somatic, or germline, I'm going to do everything I can to keep them on that PARP inhibitor because of the unbelievable outcomes. And I would even argue in HRD positive, when we're using it with Bev, we're seeing similar type outcomes, not as mature and not as robust, but similar.
So, Richard, can you talk a little bit more about the effect on the bone marrow of PARP inhibitors? We already talked about cytopenias. You can see anemia. Sometimes patients require transfusion. What is seen? And also there's been a question of, do you increase the risk of AML? We're doing a program tomorrow morning on AML and MDS. So what about PARP inhibitors and bone marrow, Richard?
So anemia, I tell patients there is a risk of anemia, fatigue, nausea, and the fourth one is the 1% roughly risk of acute myelogenous leukemia or myelodysplastic syndrome. The anemia seems to happen relatively late, and there was a story that it was more in folate deficient patients. You may or may not know the American diet is packed with folic acid, so that's pretty rare. It didn't really pan out, that story. But you definitely can get sort of late toxicity in terms of anemia. If you get really anemic, I'm sure Dave's the same. I think the lowest ever I got was a hemoglobin of 6.2 on a rucaparib clinical trial. You have to stop, transfuse, only restart when your hemoglobin is above 10, and you have to significantly dose reduce. On drugs, like I have 2 patients with rheumatoid arthritis, one with HIV meds, who are down at tiny doses of a PARP inhibitor because they just can't tolerate them when they're given in conjunction with other drugs.
So, dose reduction and of novel agents is something we've talked a lot about already. A lot of times you're not really sure as you go down, is it going to have the same anti-tumor effect? But if the patient can't tolerate it, you don't have too much choice. Let's hear about another case. This is a 67-year-old morbidly obese lady who had a somatic, so this is not germline, a somatic BRCA mutation in the tumor. We see in one of the slides I just went through, most people don't have these, so we're picking out these cases because, they're really the leading edge of where this is all heading. What happened with this woman, Jaclyn?
Yeah, so this lady, when she first presented, she had significant disease, stage 4 disease, pleural effusions. She had disease that was all around her porta habitus and lots of disease around the diaphragm as well. And so we had to do a neoadjuvant approach with paclitaxel and carboplatinum. And so ultimately she got to through 6 cycles of chemotherapy and was able to be resected. So we did resect her to a no gross residual disease and followed by 3 more cycles. So she had 9 cycles of Taxol carbo. And then we put her on olaparib maintenance. And you have to remember, the more chemotherapy up front you get, the more that you are disrupting or you are affecting the bone marrow, and so they're at higher risk for having, a hematologic toxicity with now these PARP inhibitors that have the same effect. And so we started her on olaparib maintenance, and then about a month later, with her labs, we saw a decrease in her platelets. So she had thrombocytopenia. So held the drug, repeated her labs every week, because once you have something like that, you need to repeat your labs every week, so making sure they're recovering from that. Once they're recovered, you can restart your olaparib. We did ultimately end up having to dose reduce her, and then she began to have anemia the next time we drew her labs. And so she got down to actually 6.2 on her hemoglobin. We gave her 2 units of blood, and now she is back on 200 milligrams of olaparib and currently doing okay today.
What's it been like to take care of her? How is she to work with? Do you feel she's partnering with you in terms of getting through this therapy?
Yeah, she really is. We're kind of with that upfront education and letting her know, hey, this is a possibility. You've had, 9 cycles up front, and now we're giving you another drug. So I think it's all about education and being prepared for situations like this.
So, Courtney, any comments on quality of life during maintenance therapy? I'm sure there's a lot of variability, but talking about 2 years of therapy, maybe even more in the adjuvant setting. And, it's kind of there's not any obvious tumor there that you're treating, so it's like, adjuvant treatment. What do you see in terms of quality of life?
We start talking to our patients about maintenance therapy early on so that they're prepared for it, and I think overall that really helps them too, because they're prepared that after they finish their chemotherapy, they're going to be going on to a maintenance therapy. Prior to starting the maintenance therapy, we do our best to make sure that they tolerated the chemotherapy the best they could, and we were managing those pre-existing toxicities. But overall, I think our patients have a very good quality of life, and the toxicities from the PARP inhibitors seem to be very manageable. And so if a patient's having nausea, oftentimes just taking an antiemetic prior to taking the PARP inhibitor does the trick. And, fatigue, we've found some tips that we can help our patients, like Dr. O'Malley mentioned, the timing that they're taking it, or, doing other interventions with physical activity, physical therapy, things like that. Overall, our patients, I would say, have a very good quality of life while they're receiving treatment with the maintenance therapy.
So I've just been flipping through some of the recent updates of these trials. Of course, we first saw these trials several years ago, and as Dave was talking about, as time has gone on, we're seeing continued benefits of these patients over time. Let's talk a little bit about recurrent disease. Some pretty strange things have happened in the ovarian cancer space, Richard. Specifically, PARP inhibitors initially in ovarian cancer, like most, cancers, you start out using it in very advanced disease and start moving it up. That's what happened. But then when they started to look back at some of the trials used in recurrent disease, there was concern about whether there was benefit or whether there even might have been some negative effect. Very controversial move. A lot of the docs were not very happy about it because the FDA actually removed the later line indications for 3 of these agents, so they could no longer be available. Richard, I had cases of people present me cases of where they used a PARP inhibitor 5 years ago. A patient had a great response, and now they can't do the same thing. And he kind of capsulized. We could spend an hour just talking about what happened. But sort of bottom line of what happened in terms of the whole issue with the FDA and PARP inhibitors and later line recurrent disease.
Yeah. So It's exactly as listed there, and it wasn't the FDA that mandated this. The pharmaceutical companies saw this potential about 30% worse, what we call a hazard ratio of 1.3, meaning sort of 0.3 worse than you might imagine, in terms of overall survival, how long people lived, not whether they lived or died, in late-line therapy. And so Aerial 4 for rucaparib was the first one from Clovis, and then I was the lead on the Solo 3. And what was interesting about that, the third line was like 1.1 hazard ratio. It wasn't that impressive, but fourth line was like, wow, we really are doing something. We're either really damaging the bone marrow with hematologic toxicity, we are setting up for resistance, and so failure of chemotherapy later on. We are having reversion mutations, and so losing that sensitivity to therapy, both PARP inhibitors and chemotherapy later on. Or there's the sort of seeds of myelodysplastic syndrome evolving into acute myelogenous leukemia that's sort of being triggered by these. And the reversion mutations during Solo 3 went from 3% when patients first went on study to 30%. And that was continuous treatment. So the Darwinian pressure to get more mutations because you're disrupting DNA damage repair is big. And this is important. Patients have to be informed. I had a patient this week who has just come out to her 9th year on a PARP inhibitor.
Wow.
And so I had this uncomfortable experience where I had a conversation because I said, I did talk to you about this. And she said, yeah. But her gyn-onc had gone to see it and said, why has Richard got you on a PARP inhibitor still? It was like this panicky moment. It's like, oh, I'm poisoning my patient. So we actually had this great conversation about, okay, well, you've been done amazing for so long, and we are actually going to withdraw it at 10 years and see how she does. And we sort of hand waved about, well, maybe taking the pressure off your bone marrow, a few years off, you could use it again in the future potentially. So patients who are not yet started on therapy, we absolutely respect this. Almost universally, for the patients who I have 5, 7, 8, 9 years on a PARP inhibitor, almost every patient we have a conversation with do not want to stop their miracle drug. So taking away an effective therapy late on in effective treatment is really hard, but this is really about how we think about the drug. And so the message is first-line therapy. When we have a chance of cure, nobody should miss out on their PARP inhibitor. So we're moving therapy up to a frontline therapy where it makes the biggest impact.
Yeah, so as time goes on, you're seeing people get PARP inhibitors up front, and you don't have to deal with the issue of, what could be a statistical thing that really has nothing to do with them. They saw this in the study. They don't know why they're seeing it. David, can you talk a little bit right now about what a typical clinical scenarios of recurrent disease? For example, somebody who got chemotherapy, maybe a PARP inhibitor, whether they were BRCA or not. Typically, when would you see a recurrence, and how would you think about how you're going to treat it?
Well, classically, if they recur beyond 6 months, we're going away from these classic definitions and it's well beyond today's conversation. But, if they recur beyond 6 months, we'll go back to a platinum-based doublet. At that point, we have to have the same discussions we had in the first line. Are we going to add Bev? If they haven't had a PARP inhibitor, our options have been somewhat limited by the regulatory agencies, though I think there are opportunities for patients. We need to have these conversations. To your point about first-line therapy in the PARP inhibitors, what else do we have to do first-line? Tissue and germline testing. We continue to see patients in our practice who are third and fourth line who have not had germline or somatic testing, and we find a BRCA mutation. Well, we may have missed the window for benefit there. And so important not just to offer the first line, but get that testing so you can make that decision. Once they've recurred and we have platinum doublet, I just had a paper literally in press yesterday with regards to looking at the rucaparib data and the recurrent rucaparib data in the Aerial 3 on patients who had extreme positive response, 2 years or more of therapy. And with those patients, the most important factor beyond BRCA was their response to the platinum-sensitive doublet. They got a complete response. If their CA-125 normalized, those patients behave like BRCA patients. So my challenge with some of this is limiting the ability to have a conversation with our patients, which may be in their best interest, and again, well beyond today's talk. So platinum doublet, make a decision about Bev again, and then obviously if they haven't had testing on their tissue, to have it. This is where I move beyond testing of HRD to next generation sequencing the entire of the tumor, looking for those rare mutations I may be able to action.
So, Richard, it's interesting that David, believes that there are a lot of people not getting testing. We've been saying here for years, really, it's standard of care. You see this in a lot of parts of oncology. Yesterday, in our CLL session, we were talking about the fact that no investigator used chemoimmunotherapy up front in CLL, and yet you look out in the data, and it looks like maybe a quarter of patients are getting treated that way. Everybody assumes it's that, the docs don't know what standard of care is, although, it takes 2 seconds to look it up, and you're going to see you don't give chemoimmunotherapy. You give PARP inhibitors, you test for germline. What do you think's going on? And I wonder whether or not some of this has to do with, insurance issues. Like maybe the reason they're not getting up the novel therapy in CLL is because it's oral and expensive and you have co-pays. Do you think that could be part of why some of these women are getting tested? Or do you think it's just the docs don't know you need to test people?
I think the docs are a bit overwhelmed with
Really?
the pace of change. And so, what are we, 11 years into smartphones? And so there's a lot of talk at Harvard about how artificial intelligence as a positive thing, rather than ending the race, is going to actually change some of these things. So, your patient comes in, they've filled out their online sort of quality of life forms. Every single one of our patients now fills a quality of life form in before they come to clinic. You've got their history, and up in your window comes, oh no, don't forget about the PARP inhibitor. You do the BRCA mutation. It could be a friendly thing like at Disney where it's magic. But right now, people are in a sea of change. And so, there's not to absolve them of the responsibility to give great care, but it can be challenging.
Yeah, we've been talking about general medical oncology. We've been joking that general medical oncologists get up in the morning, they check their phone, they see what was approved, and then they start figuring out what they're going to do about it, because it has been really amazing and, great for patients, but tremendous challenge. Yeah, there was a thing this morning on the Daily, of the podcast of artificial intelligence simulating a Drake song. And I was thinking whether maybe we could get artificial...
Is Ed Sheeran going to lose money on it?
I was thinking maybe we could get artificial intelligence to simulate me asking questions, You wouldn't need me to come here at all. Anyhow, so...
Neil keeps looking at his computer because his computer says, ask Dr. O'Malley about...
All right, so now you even forgot where we are. Okay, so let's talk about where things might be heading, because Dave, this has been evolving over the last 5 years or so, but now we're looking for new things. How can we move that curve up even further? Great, it's 50% in some of these patients, but that's not 100%. And you still see people relapsing and dying of this disease. I'm curious what your thoughts are about, and we're going to talk about antibody-drug conjugates, tumor treating fields, really innovative approaches. Anything else in terms of systemic therapy? Oncology always is trying to combine things, and of course everybody's trying to combine immunotherapy with everything, including PARP inhibitors. Any thoughts about whether that strategy is going to work, Dave?
Well, immune therapy has unfortunately been very disappointing in ovarian cancer when used by itself. But Richard and I were involved in a trial where we combined immune therapy, PARP, and antivascular therapy, Bev, Durva, and olaparib. We actually saw about 88% response rate in platinum sensitive for treatment. Fast forward to, I think, last week, and we saw a press release on DUO, which is a trial looking at that triplet in maintenance in the upfront setting. That press release said the trial was positive. So we'll be seeing that at ASCO to see that though immune therapy by itself has been disappointing in ovarian cancer, combining with other agents is going to potentially overcome some of that immune resistance. Now, there's so many different subsets within these groups of patients. PD-L1 expression, which we didn't think was a marker, could be a marker now. HRD, how do you break those subsets? So there's going to be a lot to look at that trial, but the data will drive, are we in the next iteration of triplet maintenance therapy in some patients?
So, Richard, do you think that after we see this paper, of course, you know what, this typically happens, there's a press release that comes out, you know the trial is going to be presented, we know it's going to be presented in a few weeks, but yet you look online right now and it's embargoed, so we don't know how much of a benefit. We just know there was a benefit. I don't know, maybe you two have some inside information, but Richard, any thoughts about whether this is going to come into practice? And also any issues about toxicity? When you combine a checkpoint inhibitor and PARP inhibitor, it kind of seems like they have different, toxicities, but any issues that you would expect maybe be a problem?
Yeah. So there's sort of two answers to that. So I don't want a generic retirement package, and patients very soon are going to want a unique, personalized treatment approach, and that is unequivocally going to be the case. You have an ARID1A mutation in a clear cell cancer, you do not want to miss out on immunotherapy, and it's a completely different disease to what we've been talking about, the high-grade serous ovarian cancers. So the problem with these trials is they're not designed to mask benefit, but you can often have not enough arms on the trial to really give you answer. This is a trial that is not going to give us a definitive answer. The two first trials, atezolizumab and avelumab, were both a complete bust. And so we hope that PD-1 is a better target. CTLA-4 with PD-1 is an even better target. And modifying, heating up the microenvironment so the T cells are really active is going to be key in ovarian cancer. There's lots of hope. The second bit is that, unfortunately, we did these sequential trials, nivolumab with bevacizumab, and then with rucaparib. Our clinical sense is that there's a ton more toxicity than there is efficacy. So adding many of these agents together really, unfortunately, may negatively shift the pros and the cons. And if you think of Ipi-Nivo in comparison to single-agent PD-1 in melanoma, I mean, it's like you've got a really effective therapy. Nobody wants excess immune toxicity. And so it's going to be exciting but challenging to get to the best immunotherapy for ovarian cancer.
I'm usually the pessimist. I'm usually the pessimist.
So, I would put up let's hope CAR T cell works in ovarian cancer, but we've done 2 trials, they were both a bust, we're waiting for our third one. Getting CAR T cell to work is really difficult.
CAR T and ovarian, of course, we've been talking about bispecifics, also similar kind of mechanism. Is that being looked at also in ovarian cancer, Richard?
Yeah, so a bispecific is an antibody. So normally it's like tight Y. You clip off the end of the antibody so that you can splay these arms. One grabs one thing, so Regeneron's antibodies grabs the T cell and the tumor cell through MUC16, which is the 16th mucin, which is CA125, knocks the heads together, gets them to do an immune reaction. And you get what's called cytokine release syndrome, CRS. So they're quite toxic. They are very exciting, and then it was like a 24% response rate to ubamatamab, which is REGN 4018. So it's like, again, that like sort of PARP inhibitors is like magic, Disney, but immunotherapy we're all a bit more pessimistic about.
That's why we don't use
Can you tell Richard's son works for Disney?
Yeah. So before we get more into like where things are heading and where things they are now, because we have an antibody-drug conjugate already approved, mirvetuximab. We're going to talk about a case of that in a second. But one other thing I wanted to just ask and start out with Courtney, there's some of the symptomatic issues that come out along with ovarian cancer as the disease progresses, and frankly, in patients who die of the disease. Of course, one of the things that we hear a lot about are effusions. We've already talked about that, ascites, pleural effusions. But what are some of the common palliative symptomatic issues you have to deal with, Courtney, as the disease progresses?
Most commonly, these patients will have like abdominal pain or discomfort or bloating or distension, changes in their bowel or bladder habits, so they might have a new onset of constipation or sometimes even like decreased urine output if they're having a big pelvic mass putting pressure on their bladder. Like you'd mentioned, the effusion, so they can sometimes have like a cough, a dry cough, or shortness of breath. The ascites, if they're developing a lot of fluid in their abdomen, they'll have changes in their appetite where they're not able to eat as much or they get full easier, and sometimes some discomfort from that as well.
Jaclyn, any comments? And what about the use of drainage and sclerosis for studies in pleural effusion?
Yeah, definitely. We like to say, if you are having that abdominal bloating, abdominal ascites that are beginning to affect how you're eating, how you're breathing, then we definitely will start intervening with some paracentesis. We like to not do too many of them because there's always a risk that comes with paracentesis as well. So you have to think about risk of infection, or again, seeding the area to the place where you have put your paracentesis in. You can tumor can begin to be in the same site as when you do the paracentesis. So there's all the different things that you have to kind of counsel the patient on. Getting thoracentesis as well, draining that fluid off of their lungs so they'll be able to have that quality of life and be able to breathe better, not have that extensive cough that they may. Another thing too is that they can have extensive lower extremity swelling. That doesn't happen to everyone, but it can be alarming to those patients that they're beginning just to kind of fill up with fluid everywhere. And they want to know, why is my leg so swollen? And you have to educate them. This is unfortunately part of the process. A lot of times their albumin is low. They're not getting the protein that they need. So education in regards to getting their protein levels up and having as much as they can a diet that will support their appetite.
Courtney, any comments in terms of advanced directives when you start talking to patients about that and how you talk to patients about it?
We try to implement at their new patient visit just to say, we're getting all your records, and try to make it a way of introducing it to them then, because a lot of these patients don't have one, or they're not even aware that they should be having one. And so we kind of make it part of that initial process, but then as their cancer, like if a patient comes in with recurrent disease, we start the discussion then briefly, but as their cancer progresses, and if we start to talk to them about comfort care, then we make sure that they have all their affairs in order then.
So Dave, your patients are often offered clinical trials. You have a very, very active clinical trial. How do you see people responding to that option? Do you generally find them interested in clinical trials, or what are some of the obstacles you encounter in bringing people in trials? Of course, when you look at trials, particularly of new agents, you're looking at the possibility that they might actually have treatment benefit, but there are also obstacles. What do you encounter, Dave?
Well, the obstacles are real. Clinical trials often will have more visits. Columbus, Ohio, literally the middle of the country, the middle of the state of Ohio, within 2 hours is some of the most underserved areas in the country, in the Appalachia area. So we have patients who really struggle with reliable transportation, young kids at home, you heard earlier. I've had patients say, and I've said, stay up here for this extended treatment for the radiation. They said, I don't have anybody take care of my dog. The support that they have, we're doing a much better job of providing support and equitable support across to gain access for all of our patients for clinical trials. Because you imagine those with less support are less apt to enroll on clinical trials. So acknowledging that is a problem, providing support, and now we're starting to see support be provided in the trials. So at your site, make sure you know, because we often don't even know that it's been negotiated in the contract that they can have reimbursement for travel or to stay. I will say to my patients, my first choice is a clinical trial, because I know right now we're doing pretty good, but we can do better. And if a clinical trial is what we're doing now versus what we could be doing in the future, I'm going to give them what I'm doing now outside of clinical trial, but maybe they'll have access to something that's the next cutting edge PARP inhibitor, antibody-drug conjugate. And so when we talk about that, when we have a change in therapy or new diagnosis, the first thing we ask is, which clinical trial are they eligible for? They may not take advantage of it, but we have a conversation, a shared decision, and talk to them about not only the option and availability of new therapies, but the altruism. We don't talk about the altruism clinical trial enough. This may not just benefit you, the patient sitting in front of me, but this may benefit generations of patients, women beyond you. And I really think we need to start to bring that into the conversation because that resonates across all of our patients, no matter what background.
So, Richard, we know that actually now Congress has said you have to have a plan to address the potential disparities that we've been seeing for a long time in access to clinical trials. Can you comment from your point of view about some of the obstacles to get patients in trials? We're about to talk about some new strategies in ovarian cancer. We did a program recently, we were talking about bispecifics, and we were interviewing patients. And I did a video with a patient who was on we were talking about bispecific for myeloma, and that he had been on it for a year and a half, great response, no symptoms, and the day I interviewed with him was the day it was approved. So he had a year and a half, lead, and he actually got it earlier than in the approval. So we know it's not like, kind of like 10, 15 years ago where you were doing trials of chemo A versus chemo B. You knew it wasn't going to be very different, but you now have the possibility of maybe you're going to get into something that's really going to help you, and yet you have these obstacles. Any thoughts?
So we just did an annual education, what it's called Health Stream, and one of the big focuses was like a more than an hour-long video that did a beautiful job of putting you in the shoes of minorities within healthcare to overcome the challenge of the diverse needs of patients and our diverse staff with the message, we are better together. And this is going to sound terrible, but it was the first time I really believed, we're going to be better together when you involve everybody in a better outcome. I just had a super patient who came up the East Coast, got terrible care from everybody, landed in our clinic, too sick to get surgery, primary medical therapy, and we managed to get her into what's called the EPIC-O trial, alpelisib, one of these breast cancer drugs, with olaparib versus standard care. And so I offered her 2 envelopes. In this envelope is the best chemo I could give you. This envelope is some of the new tablet treatments. Both would be great for you. It's not you or me choosing, it's just a computer choice of one of those 2. We used lots of strategies to get around a way to in a fair, comprehensive enough, but clear and relevant way present randomization to her. And she bought in, and she did terribly on trial. She had awful disease. But the bigger team of care in a clinical trial, we felt so proud of ourselves that we'd managed to get her in, managed to keep her on, care for her on a clinical trial. So it wasn't a great outcome, stable disease for 5 months, but we felt really good that we'd gone that extra mile, we'd made that extra effort.
Well, also she had, for a period of time, hope that she's getting a therapy that she wouldn't have had otherwise, and hope feels good. We're about to hear about 2 patients who actually went on clinical trials, but just coming back to you, Jaclyn, I'm kind of curious what reactions you get from your patients when you bring up the possibility of a clinical trial.
Yeah, so I think there's initially some hesitancy into having a clinical trial. They don't want to be, quote unquote, a guinea pig. Am I going to still get the care that I would have gotten before if I choose to go on this clinical trial? So it's kind of like you said, just presenting the options to them in ways that they can understand, give them the opportunity to go home, read all the consents, answer any additional questions that they have. But I think overall, once you provide that education to them, have the time to go home, talk to their family, talk to their friends, then generally speaking, these patients are opt to go on clinical trial. Some hesitancy sometimes when they say, I know someone who did this and this happened to them. So it's kind of breaking down those barriers, maybe explaining, yes, that happened to them, but this is a totally separate incident and those are totally separate drugs. So just really educating them. And ultimately, we find that most patients tend to go on the clinical trial as long as they're eligible.
All right, we're going to hear about 2 patients who actually went on clinical trials of antibody-drug conjugates. This is something we've talked about a lot this week. Yesterday morning, we're talking about now first-line therapy, diffuse large B-cell has an antibody-drug conjugate. We've already had one in Hodgkin's. You all know in cervical cancer, there's an antibody-drug conjugate, tisotumab that's used. Bladder cancer has 2 antibody-drug conjugates that are approved. Before we hear about these cases, Dave, how do you explain to a patient what an antibody-drug conjugate is?
Yeah, there's probably 2 or 3 that I found are effective and I would explain. And I think one of the most effective is I say there's a connection on the cancer, which is not on your other organs or tissues. And I will call it a protein, but I say that there's a connector. This drug connects to that and then releases its contents into the cancer cell, directly then impacting the cancer cell. Antibody-drug conjugate. So that's the way I found. I've heard other people describe it as kind of a torpedo where you pop into the cell, then release your payload in. I don't think most people really understand what a torpedo is, so I've gone away from that.
You need to use Disney language.
Tell me, man, tell me.
All right, well, let's hear about this 60-year-old woman. She'd had multiple lines of therapy, maybe, I guess, running out of options, but still a young woman. What did you say to her about getting, now mirvetuximab at this point has actually been approved, but what happened with this lady?
Yeah, so she actually presented to us a couple of years ago very interested in mirvetuximab, and at that time she wasn't eligible for any clinical trials that included mirvetuximab. So we treated her with standard of care chemotherapy, and then as soon as mirvetuximab became approved, we tested her for the folate testing, and she was positive. She had 76%. So we started her as part of standard of care on mirvetuximab, and she's doing really well. She was prepared for some of the ocular toxicities because she came to us specifically for this treatment, so she was aware of the possible side effects. We still counseled her on the treatment plan, the schedule, the eye care regimen that she would have to do, the possible ocular toxicities, as well as the other side effects, and she was very interested, and she has had 6 cycles now. She's doing really well. She had a really good response after the first 3 cycles, and she had some ocular toxicities after the first 2 to 3 cycles, which is when we expect to see those happen. She just had very mild blurred vision. She had pre-existing dry eyes that actually improved once she saw the eye care provider for her baseline eye exam, and they recommended these lubricating eye drops. So overall, her dry eyes have improved, and she's no longer having blurred vision or any other ocular toxicities.
So for those of you who are like, what, eye toxicity? Incidentally, we just did an entire program just on eye toxicity in oncology. This is a new thing. It's developed particularly with antibody-drug conjugates. You mentioned folate receptor. So Richard, can you provide a little bit of a translation? What is mirvetuximab? What do we know about efficacy? What about toxicity? What about the eye thing?
Yeah, so mirvetuximab is a antibody, so meaning that protein your body naturally produces from its sort of artillery B cells to bind to things that are foreign in your bloodstream. And so this in the 70s they discovered these antibodies, and now they've been developed so they can bind. I use silver bullet language is what I tend to use. So they bind to the folate receptor alpha, which is in lots of places, but it's overexpressed, lung, prostate, ovarian cancer. And it has a thing called DM4, which is a very toxic. It's like it's like paclitaxel, but it's like 100 times as potent, and it poisons the microtubules that enable protein movement and DNA movement in cells. And so you've got this toxic payload that's linked to the antibody on the sort of side, and the antibody goes in and finds the target. The studies were really exciting. There was a big problem with how we actually measure the folate receptor alpha. That's now really been sorted out. But about a third of people have enough folate receptor alpha that they can get this drug, and we love it. It's much kinder in terms of general quality of life and toxicities, a small risk of an asthma-like syndrome, pneumonitis, and about half the patients get some blurry vision. They have to take lubricating eye drops and steroid eye drops, and they're quite strong steroid eye drops, so a lot of patients are going to get a bit more cataract, but no terrible toxicities. So different kind of toxicity profile, and we love it, especially Dave was mentioning earlier on with bevacizumab. Dave led the trial when we mixed mirvetuximab with bevacizumab. I can't remember, was it like 54% or something?
50, yeah.
It was a very high response rate. And what was really good was that, I had a patient on for 12 months, 11 months, 9 months. It was a really it wasn't like a 4-month palliative chemotherapy benefit. It was a really durable benefit in those who responded.
So we may love it, but then the patient may or may not have the same opinion. I'm kind of curious, Jaclyn. I've heard people say that when you bring up ophthalmic issues to patients, a lot of them get pretty nervous. What have you seen with this agent? How do people respond when you say, well, you may see some problems with your vision, you're going to need to be screened by an ophthalmologist?
Yeah, overall, I think that they respond pretty well, actually, the experiences that I've had. You know, you do have the occasional patients that are very concerned about losing their vision, having worsening blurred vision. But I think overall, again, just explaining exactly what the expectation is, that you probably will have some, you know,
Keratitis.
thank you. You will have some of those toxicities, but they should be short-lived and very manageable. And so as long as you're seeing your eye physician and getting those regular exams are very manageable. So as long as, again, you're educating those patients, telling them the expectations, letting them know that you probably will have one, but very manageable, then they're up to go ahead and receive the treatment.
I mean, you are going to be seeing patients, if you haven't already, getting this agent, so you're going to be dealing with this. It's not too many options once you get out in the recurrent setting, which brings up this other patient, a 60-year-old woman, also heavily pretreated. She got a different antibody-drug conjugate. I like to call it UPRI because I have a hard time pronouncing the whole thing, but maybe the faculty can pronounce it better. And we'll hear a little bit about that. Before Courtney goes into it, though, David, can you explain what UPRI is, how it works, what the target is, what we know about it? At this point, it's not approved. It's just in clinical trials. I think we're trying to figure out the right dose. What do we know about it so far?
So I'm going to call it UPRI. I mean, tomato.
UPRI.
Okay. So no, I can't pronounce it any better. You did. UPRI's good.
UPRI.
That's why I call MIRV,
MIRV, right.
not mirvetuximab vedotin. So, you know, UPRI is a very similar antibody-drug conjugate, except instead of the folate receptor, it's called the NaPi2b, which is sodium transport chain receptor. Similar antimicrotubule paclitaxel-like, also very potent, but a little bit different. Instead of DM4, it's called MMAE. And what we see is is a higher expression within cancer cells of this NaPi2b, and we're able to connect, again, releasing its cells. This is a drug, the trial in platinum-resistant ovarian cancer has completed enrollment. And now we're actually moving in earlier lines of therapy into a maintenance at a lower dose, in a maintenance setting in the platinum-sensitive space. Earlier, we talked about some of the challenges in the platinum-sensitive space, losing indication for PARP inhibitors. Now we're looking at new maintenance strategies in recurrent patients. And UPRI is one of those agents to include MIRV with BEV that we're looking at in the platinum-sensitive maintenance.
So, Richard, this is the so-called waterfall plot. We've shown a couple of these. I always love these things. Each one of these lines is actually a patient. And the lines represent the tumor diameters. And if it's going down, that means it's shrinking. If it goes all the way down to 100%, that's a complete response. If it goes up, they're responding. And it looks like most of these patients, at least in this particular trial, were benefiting. 2/3 of them, it's going down. Also, the issue of tolerability, and this always comes up when you start with a new agent. You want to have the dose that's going to be effective in terms of tolerability, in terms of efficacy, but also you have to consider tolerability. What happened with this lady? I know she had a lot of issues with it.
Yeah, she, after the first cycle, developed a lot of toxicities, which is common after the first infusion. She had abdominal pain, pretty significant fatigue. She also had diarrhea for like 5 to 7 days after the treatment, which is also a common side effect. She also developed a rash, which with this treatment, it seems to be like a few days after the treatment, they can sometimes develop a rash. For other patients, giving pre-medication with steroid or giving them like a steroid taper for a few days after has helped, but hers just still kind of popped up regardless of our interventions. But it was grade 1, not very bothersome to her. So she was very interested in clinical trials in general, and she was okay with the toxicity because she was having a good response. And so we just found ways to implement mitigation strategies with weekly IV fluids, keeping a close eye on our electrolytes, and things like that to try to help with the fatigue the best we could, doing antidiarrheals immediately after the infusion to try to prevent the diarrhea from happening or minimizing it if it did. And then the abdominal discomfort was only after the first 2 infusions and improved thereafter. So While she did see a lot of toxicity, she also had a better response than she'd had on her prior treatments. And so she was accepting of these toxicities and just worked with us to find the best ways to make the symptoms manageable.
So she actually had an objective response. The tumor shrank down inside?
Yeah, she had a partial response after 2 treatments.
And did she have any tumor-related symptoms that improved? Or just...
Yeah, she was having some GI symptoms. She had this mass kind of pushing near her rectum, so she was already having pre-existing bowel problems, and those improved after she started treatment.
So, you hear stories like this, Dave, and you want to figure out a safe way to give a drug that works. And here, you're in the middle of this. You're the investigator on the study. Can you talk about sort of how you thought through trying to figure out a way to get the right dose and to get patients as comfortable as possible, and particularly how you deal with the issue of fatigue that's so multifactorial, and how do you figure out whether it's the drug causing fatigue or some secondary issue? As an investigator, how do you try to, sort of get things to where it's going to be helpful to patients?
Let's take the easier question first, which is how do we decide on the dosing? And you see, the slide up right now where we had, I think, about 66 patients versus about 30 in the other arm. And we saw that the 43, the dosing at 43 was markedly more toxic when you can see the patient. This isn't as impressive when you look at it on this bar graph, the difference between the 43 and the 36. But taking care of the patients, these persistent grade 2 symptoms, to your point, fatigue, where it doesn't hit grade 3, which basically means they can't get out of bed, but they're really impacted. So as we look at mitigation strategies, for example, on UpRi, we started finding out in the platinum-resistant, again, the higher dose patients, we would bring them in weekly, and we'd have them set up for IV fluids and antiemetics. And if they were doing well and they're feeling well, we would just cancel it. So getting to the fatigue on that, making sure they have adequate oral intake, fluids, and obviously nutritionally. We haven't gone into some of the stimulants as much as maybe we should, where we look at can we give medical management to help with the energy, making sure well before that, sleep-wake cycles, being active. Probably one of those under-talked about interventions that we have with our patients is physical activity. Trial after trial has shown if you're physically active, yoga has been amazing, every positive result, yoga and symptoms of chemotherapy, that they tolerate it better. I think both from a mental and a physical. So having that education about what can we do, sleep-wake cycles, regular diet, maybe small frequent meals, and regular exercise really seems to make a difference well before we go to the pharmacologic kind of interventions that are available to us.
Yoga, that's interesting. Jaclyn, any thoughts about...
I do a lot of it.
You do it yourself?
You can tell, can't you?
Interesting.
No, I can't even sit cross-legged. Are you kidding me?
Kind of curious, Jaclyn, any thoughts about yoga or complementary strategies like that to deal, acupuncture, anything you've seen work?
Yeah, sure. We do recommend being as much physically active as you can. I think that's some of my initial counseling to the patient is to be as active as you can, to get like you said, the small, frequent meals. But yes, of course, using those yoga strategies or trying to be as really active as you can. I mean, at this point, these patients are quite fatigued. They have lots of symptom burden. And so maybe yoga could be those things that they could do, and not being like running a marathon or doing the treadmill, but it's just those stretches, those deep breathing exercises can really complement the things that they're able to do at home while they're, relaxing, watching a book, just taking their time away from getting their mental and physical health a little bit better. And so I think definitely I haven't really worked with,
Yoga?
No, the needles.
Oh, acupuncture.
Thank you, my goodness. We don't have that. Yes, we do not have, we don't have that available to us. And so I've heard it does wonders, but I haven't actually worked with a patient that's undergone that, but I have heard that it worked really well.
Courtney, any comments about complementary strategies that you found useful for some of the symptoms of people, particularly fatigue?
We really utilize physical therapy at our office. We found that implementing it early on, specifically for the neoadjuvant chemo patients, it's helped with their surgery outcomes, it's helped with their chemo outcomes. It helps us keep them at their same dose level and keep them on treatment longer.
Physical therapy? How often do they go?
It depends. The physical therapist will evaluate them and kind of do an assessment, and oftentimes they can teach them exercises that they can be doing at home to prevent them from having to come in for extra visits. But if they're on a weekly chemo treatment, we have them see them when they're in their weekly. If they come in every 3 weeks, we try to do as much as we can at home. But some patients really enjoy it and benefit from it, and they're willing to come in once a week if they're able to.
Interesting. Have you had acupuncture at your place?
We have it at Ohio State. We don't use it a ton. We've had a couple patients try it and it hasn't made, mostly for like neuropathy or nausea, they've tried it, but not so much for fatigue.
Richard?
So I have a great acupuncture story. So we did a randomized trial in which people got sham acupuncture or real acupuncture.
Really?
Ursula and I did.
Wow.
And so one of our surgeons, A.K. Goodman, is an acupuncturist. And so it was really interesting, but people's white count was higher with acupuncture, but would have been much higher if we got them to run up and down the stairs with exercise. And so in the Boston area, there is this acupuncture called Tong Ren, in which you get a hammer and you beat an effigy, sort of pagan style. And so I had a lot of patients who were coming in saying, I really want this Tong Ren. Do you think it works? Like, you hit a dummy with a hammer? Do I think it works? No, I don't think it works. And so one of my patients said, Richard, you've got to come along and see this. It's just fabulous. So I went along, and this therapist was like an abrupt Chinese man, you know, okay, what wrong with you? And the lady in the front row said, oh, you know, I've got metastatic breast cancer, and, you know, my kids are all, and like everybody was like, oh, there's this agony patient, you know, cachectic, sick. And he said, okay, like, we hit F7, I can't remember what it was. And everybody in the room started hitting F7. And there was this like thrumming pagan. But what was happening was everybody's heart was going out to this woman. It was exactly like church. You know, Mrs. Mabel Jones has got breast cancer. Can we pray for her? And we all leaned in and prayed. I was like praying for this woman in the front row. And it was just lovely. So if you can find communities of experts who will partner with you to do things. I have a patient who I had a patient who had a very rich banker husband. She set up a fund to pay for patients to come in for treatment. So they get picked up by a chauffeur. You know, it's like volunteers. It's done on the cheap. But it makes all the difference in the world if somebody, you know, loves on you as you're coming for chemotherapy that day.
Life at Massachusetts General Hospital.
Yeah.
All right, well, now you talk about something completely different, and we're going to talk about this tonight in our lung cancer program. And wow, we're about to see a paper presented in a few weeks that could change our lives a lot. We'll see, because we don't know the data. Same thing as always, there's a press release out, and we don't know. But it's a pretty interesting modality, Dave, tumor treating fields. Can you explain what that is? This is actually approved in glioblastoma and mesothelioma. I remember when we were at the Society of Neuro-Oncology meetings, I think it was about 5 years ago when this first came out, and people were like, what is this? And now it's used routinely, and it seems to benefit. The question is it going to benefit other patients? It's being looked at in ovarian cancer, and there is a positive trial in non-small cell lung cancer. It's going to get presented in about 3 weeks. Nobody knows how positive it is, but if maybe it's super positive, you might be doing this a lot soon. But we shall see. What is tumor treating fields, Dave?
So, Neil, I've caught so much crap for this, you can't imagine, because I'm the U.S. lead for this trial, which is weekly paclitaxel plus or minus tumor treating fields. There wasn't a sham, so it's not placebo-controlled. But basically, it's arrays that they wear. They wear 4 arrays, and it's electronic magnetic fields that pass and actually preclinical and preclinical data which shows disruption of the microtubulin, which is the same thing that kind of paclitaxel does. So we're disrupting. And we enrolled a large number of patients on this trial. I don't know if it's going to be positive, but it's a pretty amazing. People are really, speaking of alternative therapies, people really embrace the thought of electrical energy fields killing their cancer. So, as you said, it has 3 indications right now. We now know non-small cell lung is positive. Again, how positive, wait and see. But for me, it's really that proof of principle that this can work beyond the brain. And we have a pancreatic trial, which is ongoing and soon including enrollment, and a trial that should report out this year in platinum-resistant ovarian cancer. And I'm really excited, but I have caught a lot of grief when I told people about this initially, and we opened the trial across the U.S.
I mean, I'm curious, Richard, what your thoughts are. I mean, I like the idea that we're trying something different. I mean, I love that, hopefully it works. Everybody's always asking, like, how does it work? Nobody has any experience with it. We actually did a webinar with Dr. Charig Patel, who's a neuro-oncologist at MD Anderson, because I read a bunch of papers, and, there's a lot of science behind this. Richard, what are your thoughts?
Yeah, I think what's called the go, no-go decision during a phase 1 clinical trial, where you're trying to find out what's the safe, effective, and not too toxic dose. That therapeutic window, almost every phase 1 clinical trial now is trying to get what's called a signal of benefit. And so how do you make your science stringent enough that you get a really plausible signal of benefit? And so the 2 things in this was the synergy with chemotherapy, because you're trying to damage how DNA is affected inside your body. And also you tuned this, they choose different wavelengths, and I think it was 200 megahertz or something, I can't remember what it was, but it was like, you could see differential effect, like a dose response effect in chemotherapy. So there's some plausible science, but the proof's in the pudding, we just need to see the data.
So I'm just kind of curious, Courtney, what you've seen. Very few people have actually used this modality. We were doing some meetings at the Society of Gynecologic Oncology. We actually had a couple of patients with ovarian cancer treated who responded, but also they had dermatologic toxicity, rash underneath the device. What have you seen? I think, Dave, they're coming up with a smaller device, so it won't hopefully cause as much problem on the skin. But that, I think, is the main thing that's been seen. There are no systemic toxicity. What have you seen, Courtney?
Yeah, it was primarily the skin toxicity or the rashes, and they were different for everyone. Most patients would just have like a dermatitis or like an irritation from the stickiness being on their skin, essentially. But some patients would develop like an abrasion that could turn into an infection. So as long as it was a dermatitis, often if you just would remove the pad for a little bit, their skin would improve. We also found a lot of benefit in using like skin barrier cream when applying it and when removing it, so it wasn't as hard on their skin when removing the adhesive. And then also using a steroid cream really helped decrease the inflammation and the redness and irritation. If there was an abrasion or any concern for infection, then we would use like a topical antibiotic cream, or sometimes they'd require oral antibiotics. But for the most part, it was like a dermatitis, red, irritated rash on their skin. And by moving the arrays and not having them in the same spot every time, and using the barrier cream and making sure that we were like keeping the skin clean and dry, it really helped reduce the incidence we were seeing, but we did see more derm toxicity than we were expecting.
What about the practical issues? I know there's a battery that, and I think they're making it smaller, because initially I know it was kind of heavy, but from practical, I'm imagining, suppose this lung trial is really positive, maybe you're going to walk into your infusion rooms in 6 months and there's going to be a ton of people, I don't know, with this, probably not.
It does have to have a battery. It doesn't have to be plugged in all the time, so if they needed to go somewhere, they can leave it. But the battery comes in a nice little backpack, so honestly, people don't even know that they're wearing them. And there's clothes cover it, so you couldn't tell someone had one on unless if they have their backpack.
Interesting. Any other thoughts, Dave, about where this might be heading? Any speculations about what we're going to see in this lung trial and how it's going to affect clinical care?
It is, depending on the magnitude of benefit, because it is a new technology and completely new technology, and we saw it take PARPs years for its wide adaptation. So I think, depending on the magnitude of benefit, like PARPs, like antibody-drug conjugates, we will see greater utilization across, but it will probably take some time. It'll take some education. I spent 3 hours on a conference call 2 days ago talking about mitigation strategies for the dermatologic side effects. So lots of work to do, lots more to learn.
It looks like there's a whole bunch of new studies out there as well that, in looking at a variety of tumor types. and looking at a whole bunch of issues in terms of how this could be optimized. One other question in terms of moving forward, Richard, was something we talked about a lot in our solid tumor programs, and similar even in hematologic programs where we talk about MRD, which is cell-free DNA, and whether you see a future with that in gynecologic cancers, and particularly ovarian cancer. You know, this is kind of like a tumor marker. We're going to talk about PSA on Saturday with prostate cancer, but this is actually looking at particles of DNA in the blood to try to look for mutations and particularly minimal residual disease. Have you gotten rid of the disease? Any thoughts about whether or not that's going to come into ovarian cancer, Richard?
Yeah, I think it is already coming in because you can detect reversion mutations through that technology. We presented the data from the, dearie me, what was it called? So it was our SOLO3 study in ovarian cancer, and and I forget the name, in breast cancer. But we saw about half the number of useful assays in ovarian cancer as opposed to breast cancer. So that technology is a little dependent on the fact that a bulk of our tumor is in the abdomen. But otherwise, it's a great technology. So we actually use biopsy and do reversion mutation testing, use a platform called Snapshot, a next generation sequencing. You find none to 4 or 5 reversion mutations in ovarian cancer patients on PARP inhibitors.
Yeah,
so it's coming,
you're
that
talking
whole
about
technology
PARP
is coming
inhibitors.
in. Yeah.
And so what happened? The mutation changes, and therefore the PARP inhibitors won't work.
The classic one is a truncation mutation that happens in your BRCA2 mutation. You get a new mutation just before shifts the frame, which alters that other mutation, so you can read out the whole gene to make the protein that then the BRCA protein is functioning again. Remember, it's the loss of that protein that makes the sensitivity to chemo and to PARP inhibitors.
So we'll be talking about tumor treating fields in this upcoming study tonight in this room when we talk about lung cancer and a whole lot of other stuff. Thanks so much to the faculty. Thank you for attending. Have a great afternoon.
Thank you.